Everybody to our webinar on the reconciliation process. I'm joined by a couple of my colleagues today, Amanda Vaughn, who I'm sure some of you know, and Oscar Ibarra, who will be happy to answer any questions you have. We have a couple of purposes today. We first want to give you some background and sense of why we're putting you through the reconciliation process. Then, as you probably saw last week, we sent out a revised template. So we want to kind of walk through the new template that we think captures some of the concerns a number of you expressed about the original template, and then just go over the timetable. But largely, this is an opportunity for you to ask questions and make sure that we get all on the same page going forward. So feel free to ask questions as we go along. All right, so I'm going to jump ahead to a little background. I'm sure most of you know this, but just really quickly, just reviewing the kind of key metrics for the all-payer model. There's two financial metrics that we're trying to measure. The first is limiting the all-payer per capita revenue growth for Maryland residents to 3.58% a year, which is the growth in the historic growth in the Maryland economy. So you can see, since it's all-payer, but it's Maryland residents, why we're concerned a lot about the in-state versus out-of-state split. And then the other test is Medicare, and it's Medicare fee-for-service only. We, the state, have agreed to save $330 million over the next 5 years by constraining the growth in Medicare spending per beneficiary to a rate that's below the national growth in per beneficiary growth. So here again, it sort of points out it's a fee-for-service test, so we need to be able to split the fee-for-service and Medicare Advantage. And it's, again, Maryland residents. So that's, again, why we're so concerned about in-state and out-of-state. So these parameters are actually fairly challenging for the state. So the Commission is very concerned about making sure that we are able to comply with them. That's really why we're doing this reconciliation process, is we need to have the most accurate and timely information possible to advise the Commission on where we stand in terms of these waiver tests, so that they can adjust policies and funding for the hospitals to reflect where we stand. And this can have benefits for you as well as downsides. I mean, the Commission has sort of initially been pretty conservative, because we want to make sure in year one we don't come in over the targets. But if we're coming in well below the targets, that gives them an opportunity to rethink the amount of funding for hospitals going forward. So, I mean, it's everyone's best interest to have the best information so that we can provide the most appropriate funding for hospitals, and to provide stability. We don't want to every month be changing your funding levels or your global budgets because the data keeps changing. So having good information as soon as possible is really important. Sure. We have a question?
So we have a question from Scott Ryan. I'm going to go ahead and unmute you, Scott, so speak whenever you're ready.
Scott? Okay, well, maybe we'll get back to Scott a little later. We'll move on to the next page. So why is the reconciliation necessary? You all have been submitting the data as requested for a number of months now, but as we've been looking at the data, there's been very significant disparities or variances at certain hospitals between the case mix data and the financial. 20–25% variances that is not an obvious reason for that. And we think in some cases people are just, there's mistakes or errors that aren't getting caught. So that's really what got us started in doing the reconciliation, is in a lot of these different buckets, especially some of the smaller buckets, in-state, out-of-state, Medicare fee-for-service versus Medicare Advantage, there were big differences. And many of them would get corrected a number of months later, but it was skewing our analysis at the time. So as I said before, we really want to get the most current data as accurate as possible. So there's a new reconciliation template that we sent out, and we'll be showing you in a moment if you haven't already looked at it. The changes are primarily reflecting the feedback we've received from all of you, as well as our review of your initial submissions, and there was obviously some confusion as different institutions submitted the information slightly differently. So we're trying to make some improvements. A couple of the major changes is we've added columns for in-house beginning and ending adjustments, as that was an issue at almost every hospital and doing the reconciliation. We've provided more detailed instructions on completing the template so you know what we're really looking for in the different boxes. We've built in formulas into the Excel sheet so that the calculated fields will just calculate for you. And also in terms of the reconciliation targets, we've made one adjustment. A number of the small hospitals were spending a lot of time trying to resolve, a $500 or $1,000 difference because on a percentage basis it made a difference. So we're going to put a $5,000 threshold. If it's below $5,000 in a bucket, don't worry about trying to reconcile that to try to make life a little bit easier. The folks in the room are smiling at me. So, and then the new template is going to go into effect for the submissions you're doing this month. So let's jump ahead to that new template. There are a number of columns here. We've put letters over most of them to help facilitate this discussion. The categories are actually exactly the same as what you've been doing, so there's no change into sort of the categories you're looking at. If you look at columns B, C, D, and E, those are fields that we're going to fill in and send to you. So column B, whether it's quarterly or financial, would be the, say for the month, would be the most recent month of data that you've submitted. And we would just populate that for you. The abstract data or case mix data is going to reflect your original submission for that same month. Because of the lag in when we get the financial data versus the case mix, you may have submitted revisions to us already for that case mix, but we're going to be sending you your original submission for the case mix for that month. And then columns C and E are just calculated fields showing the difference between the financial and the abstract. Columns F and G are columns that you will be filling out. So column F for the financial, that's just your sort of revised financial. You may have made some adjustments or noticed some differences since you originally submitted the data. So we're asking you to put your new total financials for that month or that quarter in that column F. Then in column G, the same thing for your case mix. You'll surely have made some revisions at that point, so put in what you believe is the correct case mix at the time that you're completing the reconciliation form. And then columns H and I, again, are just calculated fields comparing the difference between your revised abstract and revised financial data. And then the sort of new columns we're adding in are J and K, which addresses the in-house adjustment issue. Asking you to put in the sort of beginning figures, so capturing what was included in your abstract data for the month, but may have been included in the financial in the prior month because there were charges in the prior month, but the person wasn't discharged until this month. And then in column K, the opposite, taking out or adding in the financial for the charges that came in that month, but you haven't actually submitted them in the abstract because the person wasn't discharged. So you're filling those two in as positive numbers, and then column L is a calculated field that just takes the end adjustment and subtracts the beginning adjustment to give the net difference. And then column M is sort of your overall unexplained variance. So essentially what we're taking here is column G, your revised abstract. We're adding column L, the net of your in-house adjustments, and subtracting column F, your revised financial, to see what your remaining difference between abstract and financial after taking into account the in-house adjustments is. And hopefully you'll be within the 1 or 2% thresholds for the month or the quarter. If not, we're asking you to provide a written explanation of why there's still a gap, and there's a little box there right below the filled-in template for you to put in an explanation, and you can certainly expand on more than a sentence or two if you need to. So that's the new template. Why don't I pause there and see if you have any questions about the template before we go on? Okay, well, we'll move on then. Slide 7. Improving the initial data submissions. These are just some things that we were looking at where we were first identifying that there were some issues. So, for example, we were comparing the financial of the abstract and noticing variances in earlier months. So we just would suggest if you want to get a jump on the reconciliation process, as soon as you submit your financials, you can start comparing that to the abstract and start identifying where there might be issues. The other way that we've sort of identified it, particularly when people just sort of miskeyed a number or made an error, is comparing your charges by category, all pay or Medicare, that are for this month to the same month in the prior year. And sometimes things jump out at you where, you reported out of state of $1,000 last year and you've got $100,000 this year, and it kind of called into question whether there's some sort of a problem with your numbers. So just some suggestions and things that we've been looking at kind of up front. The next slide looks at the timetable. The timetable has not changed since what we sent out to you a couple of months ago. So the slide 8 shows you the timetable for the monthly reconciliation. So as you know, you submit your abstract data about 15 days after the close of the month. The financial data comes in about 30 days after the close of the month. And then our goal is to get you the reconciliation report, the part that we fill in within 36 days of the close of the month. We know we've been a little slow on that in the first 2 months. We had some startup issues, and then the Labor Day holiday delayed some of you reporting, which delayed our creating the reconciliation. But we think we've got our process in place now to turn this around quickly and get it out to you so that you have plenty of time to do the reconciliation. We've built in essentially 2 weeks for you to complete the reconciliation for the monthly, and then you have an additional week to submit any revised financial or abstract data that you're interested in submitting. The next slide shows sort of a truncated version of that just for the quarterly. Again, we're planning to get you the quarterly reconciliation out 36 days after the close of the quarter. Give you, in this case, 3 weeks for the quarter to complete that reconciliation and get it back to us. And at the same time, we would want you to submit any revisions to your case mix or financial data. A couple of notes on the timetable. So just to be clear, the monthly reconciliation reports are going to be for the first and second month of a quarter. And then at the end of that third month of the quarter, we're just going to send you the quarterly reconciliation. You don't need to do both a third month reconciliation and a quarterly reconciliation. You just can roll that third month into the quarterly. To help facilitate your process, St. Paul will be sending you a monthly report of the case mix data in the inpatient and outpatient categories. And they're also going to make available patient-level data in Excel for the case mix to facilitate your analysis. Finally, just some administrative details. The email is the same for submitting the reconciliation. I have it there on the slide. Again, the completed form should include the detailed written explanation if the variance exceeds 2% for the month or 1% for the quarter. And the reconciliation report, if they're not submitted, you are subject to fines. So that really completes our presentation. We're happy to answer any questions you might have.
Hi, David.
Question in the room. Go ahead.
Hi, David. This is Mary from Doctor's Hospital. A couple questions. When we're submitting our monthly data, for example, July by August 15th, August by September 15th, the time frames for abstract data means that we may still have cases that are open because we're waiting for physician queries. That's not unusual. That happens all the time. Our financials have been submitted on a monthly basis, obviously. The case mix can linger, as we know. That's why we have it open for X period of time. When we submit that first preliminary, I'll call it, for the monthlies, there will be a significant difference, especially if we're holding accounts that, not holding, but I mean we're waiting for queries to come back from physicians. So that's going to be a normal thing that we see, and I believe other hospitals may have the same scenario as well. But when we started doing the monthlies last year, we brought this up, saying how accurate or how complete are you looking for the monthly abstract data to be? And of course, we want it to be right. So there may be a delay more than 15 days for some discharges to come through or any case records that are open. Some of the other hospitals may have the same issues as well. With that said, that's why it may change again whenever we do the quarterlies, obviously. What are your recommendations? That we look at those accounts that say that they're not submitted at that point because they've not been finalized, because we are waiting for clinical data usually coming back to make sure that the case is completed? We actually are not even billing it at that point because there may be a problem with the case. Not problem, but questions that could actually provide some more information.
I mean, I guess, well, Oscar thinks about that for a second. I would say, we don't want you to submit data that you know isn't correct.
Not incorrect, but still not completed at this point. We'll say it that way.
Right. So I would say submit the best information you have, and there's an opportunity, obviously, to adjust it as we go forward. And if it creates part of, if you're not reconciled because of that, provide that explanation that there's a number of these cases that you're waiting for the queries to be resolved. I don't know if you want to add anything.
No, that's just want to explain what the discrepancies are. Then we know what to do. And we can always call you if we have questions.
Sure, sure. And I gave that scenario because July had some open cases when we submitted, but obviously August we got it again because now you're doing 2 months together. So we may have got those cases that were still from July, and then we submitted a bi-monthly data file to the commission. So we've already seen an increase, possibly. I'm not saying that we did it all the time. I'm just saying that there is possibilities. I'm sure there's some other facilities might have that same scenario too. We talked about this whenever we started doing the monthly series.
Right. It will be. I mean, if we have questions, if that becomes a reason you weren't able to reconcile, we've been following up with hospitals with sort of unusual reconciliation issues just to understand that better. So we can have that dialogue if it becomes an issue.
Okay.
All right. Any other questions?
It looks like I have a question typed in from Lori Dixon. So Lori, what we're going to do is unmute you, and if you'll ask that question for everyone to hear.
Lori doesn't have a power to enter for
Lori, if you can enter your PIN, we'd be able to unmute you so that you can ask your question. Hi, Kristen. We've unmuted you if you have a question.
Yes, is this us?
Yes.
Okay, actually, Rich Pellegrino has a question.
Good morning. My question is really a question just based on the information that the HSCRC is going to use when they're tracking our waiver test with respects to 3.58% and the $330 million. I understand the reconciliation is to help in the monitoring and the analysis to see how well we are doing compared to the waiver test. But with everything coming up with this reconciliation with respects to that the variances and the differences between the financials and the case mix data, is there more of an approach to use the case mix data with respects to monitoring versus the financials because of the implications of the charging, posting practices, as you guys have recognized, especially with in-house versus beginning and in-house, I should say. So again, it's just a question based off of curiosity. Is there more of a focus to look at the case mix when we are comparing ourselves to the waiver test?
What we're reporting to the Commission each month is based on the financial data. But as I said at the start, we were noticing in the early months of the year, the first half of this calendar year, there were often really big differences between the case mix and the financial. And sometimes the financial wasn't correct, particularly in terms of the bucket. It would be, the total might be right, but they were finding in a number of institutions that there were pretty big changes over time between in-state and out-of-state, but also between Medicare fee-for-service and Medicare Advantage, and even Medicare, non-Medicare were often off. And the case mix appears to generally be a better measure, at least initially, of some of those buckets. So we're using the financial to report to the commission, but the case mix is really critical to our being able to look at the financial and start asking a lot of questions about it if it doesn't seem to be matching up.
Okay, thank you. I have one more question based off of your response. The financial data, if we recognize, and I want to stress that this is not an issue with the financial data, but just the normal practices of healthcare business, if we recognize patient accounts that have changed from the time the financials were submitted to the time the case mix was submitted, primarily with respect to the payers. For an example, if a payer had Blue Cross and was submitted as Blue Cross on the financials, but later identified this patient really had Medicare, and then that was timely enough to submit on the case mix, what is the expectations of us resubmitting the financials to ensure that the rate commission has all of the most up-to-date data as reported on the case mix, and how often can the financials be reported again?
Hi, this is Amanda Vaughn. We prefer you to update financials as often as possible. That database is always open for revisions, and of course they're updated once a month as we pull the monthly data and run the reports. But we ask you to always keep your financials updated as often as possible.
Okay, thank you.
It looks like we have a question from Jill Mazio. Jill, you're unmuted.
Yes, can you hear me?
Yes.
Yes.
Okay, great. So I just want to go over the timetable here for October, just to make sure I'm clear. So the preliminary tape is due November 17th. So I'm assuming we will submit our tapes by November 17th. You guys will fill in column B, C, D, and E on the reconciliation with that preliminary tape. We then have an October and November tape due on 12/15, which is prior to when the October monthly reconciliation is due. So I'm assuming, which is what I did last month, is I used the October numbers that I just recently submitted on 12/15. I'll put those in as my revised numbers, because that will be the most current October numbers that St. Paul will have from that tape, and put that in as revised for the 12/22 reconciliation deadline. Does that make sense?
Yes.
Okay.
Yeah, it does make sense.
Okay. I just wanted to make sure that was right. So St. Paul will break that out. The 2 months.
They should be able to break it out. Yeah.
Okay. Yeah, that's right. They did do that for me last month.
Right, yeah. And if they don't, let us know.
Okay, so it looks like we're having trouble with somebody and their PIN. I'm going to go ahead and read her question. This is from Lori Dixon, and she says that HSCRC wants us to reconcile the data monthly for the first 2 months of the quarter. However, the case mix is cumulative. Is this correct? Do you want to answer that, Oscar?
Can you repeat it one more time, I think?
Sure. She said that HSCRC wants us to reconcile the data monthly for the first 2 months of the quarter. However, isn't the case mix cumulative?
Oh, sorry. Yes, it is. And trying to answer the question in a way that it is cumulative, and yeah, you should be able to reconcile.
Aren't we breaking it out on a monthly basis when we provide the data to them?
Yeah, we are. Yes, we are breaking it out monthly.
Right. So like the column C in the template, that's going to be for, say, the second month of the quarter. We would just show you what you submitted for that discharges that occurred in that month. We're not going to be showing you July. We would just show you what you
that month.
Just August discharges would show up in that,
we'll do it monthly.
in that column C.
Right.
We'll give one more minute for questions. Right now, no one has indicated they have any further questions.
Okay, we have another question from Kristen Johnson, and she stated she wants to know if the next submission is going to be July and August or just August.
It will be just August, because we're just doing monthly.
Okay, thank you very much, Oscar. I just wanted to ask again because I thought earlier in the presentation it said that the next reconciliation template was going to be for July and August, and then the answer to Lori's question, I guess, was it was just August. So I just want to make sure the next reconciliation that we submit is just going to be August. So the beginning in-house is going to be accounts that were here across the July-August time frame, and the ending is going to be for patients that were here at the end of August and discharged in September.
Yeah, that's correct, yes. Yeah, I misunderstood the question before. That's what cumulative, but it's not. It's just...
Oh, okay. All right, perfect.
I'm not seeing any other questions.
Okay, there don't seem to be any other questions, so thank you for participating in the webinar, and feel free to contact us individually if you have additional questions as we go forward. Thanks for participating.